Okay, and welcome to the Davies Use Case webinar being presented by Rush University on Clostridium difficile. This is the Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, Tiffany Wixton. Tiffany, I will turn the presentation over to you, and you can begin when you're ready. And thank you for joining us today.
All right, so I'm going to go ahead and get started. My name is Tiffany Wixton. I'm the infection preventionist here at Rush University Medical Center. I'm part of one of the team members for the Clostridium difficile infection intervention team, and I'll be presenting on behalf of our team this afternoon. First, we're going to start with a little bit of background on Clostridium difficile. Clostridium difficile colitis is a form of a contagious diarrhea. For patients that have active C. difficile infection, symptoms include watery diarrhea, abdominal pain, fever, and nausea or loss of appetite. C. difficile is spread as a bacteria that spreads from one patient to another, primarily through the hands of healthcare workers and through the contaminated environment. C. difficile spores are very, very difficult to kill. They can exist in the environment for long periods of time, up to 5 months, and still cause disease in people, and requires a specific cleaning product to help kill these spores. There are both modifiable and non-modifiable patient factors that increase the risk of C. difficile infection. Some modifiable risk factors include things like medications that we take, so antibiotics or proton pump inhibitors. And some non-modifiable patient factors that increase the risk of C. difficile infection include things such as other diseases that our patients may have, advanced age of patients, et cetera. When it comes to the severity and impact of C. difficile, in 2011, there were over 500,000 C. difficile infections in the United States. Toxic megacolon can be a very rare complication of C. difficile, so it's seen in less than 3% of cases, but it requires surgical removal of the bowel and may result in patient death. If you refer to that little picture in the bottom, that's the picture of a patient who's had their colon removed due to toxic megacolon. Around 29,000 patients died within 30 days of their initial diagnosis of C. difficile infection, and in 25% of our patients, C. difficile infection can recur. In addition, there's also many intangible costs to the patient that include the psychological stress of having a C. difficile infection, pain and suffering, and potential change in social functioning and activities of daily living, especially for those patients that do develop toxic megacolon and need to have their colon removed. When we talk about the financial impact, according to a meta-analysis completed by Zhang et al. In 2016, the total costs in the U.S. attributable to C. difficile infection management was $6.3 billion. So that was just for 1 year. The cost of C. difficile infection in the United States varies based on the onset of infection. So for the average cost of hospital onset C. difficile infection, it is about $34,000. Average cost of a community onset case of C. difficile infection is around $20,000. We're going to start off with a couple of definitions, how we report C. difficile infections, and the next slide will go into how we compare ourselves to other organizations. So for reporting C. difficile infections, we report through the National Healthcare Safety Network. This is a national database that hospitals report into. C. difficile infection is a mandatory reporter to the National Healthcare Safety Network, and we report using lab ID events. So basically, it's the most objective measure of C. difficile infection. So for community onset period, it's considered days 1 through 3 of an inpatient admission. There is a category that's community onset healthcare facility associated that NHSN will apply to some of the cases that are reported, and that's if a patient has had an inpatient stay within the previous 4 weeks of their new onset of community onset C. difficile infection. Hospital onset C. difficile infection is defined by the NHSN as day 4 of inpatient admission and after. So any patient that tests positive for C. difficile infection on day 4 of the inpatient admission or after is considered to have acquired hospital onset C. diff. This accurate categorization helps us to determine the burden of patients in the surrounding community, as well as identify true hospital onset cases so that it will help us to identify organizational opportunities. When we look at our data and compare it to other organizations, we use a couple of different measures. The standardized infection ratio is a summary measure used to track healthcare-associated infections over time. So basically, we're looking at the number of observed at our organization over the number expected. The SIR is adjusted for by facility and patient level factors that contribute to the healthcare associated infection risk. And the calculation is risk adjusted based on several variables, which can include the facility type, medical school affiliations, number of ICU beds. When we talk about percentile ranking, this compares our performance to all other acute care hospitals. We use this data to create both organizational and unit-based goals. So our organizational goals are based off of the standardized infection ratio and again the percentile ranking. Our unit-based goals are typically going to be based off of rates. When a unit is not expected to see at least one infection, you cannot generate a standardized infection ratio. So in order to be able to compare units over time, we go to the rate. So our RUSH C. difficile baseline, first all positive C. difficile tests are identified by the lab, or again reviewed by infection prevention. They're categorized as community onset or hospital onset, and we thoroughly review each case. It's through this case review that we're able to identify opportunities for improvement, sometime in testing, sometime we look at temporospatial association, things of that nature. Monthly, the Infection Prevention Department reports all of the C. difficile cases to the National Healthcare Safety Network, which then also categorizes and assigns community onset healthcare facility associated, and hospital onset determinations. And then quarterly, the National Healthcare Safety Network calculates that standardized infection ratio, which can be compared to our national peers for benchmarking purposes. For FY16, our standardized infection ratio was 1.28, which means we were higher than expected, right? So if we had a SIR of 1, that means that we had the number observed was equal to the number expected. So for FY16, we were 1.28, and we benchmarked at 80% compared to our peers. And we're looking for a lower number. Lower is better. So once we took a look at our data and determined that C. difficile for our organization was a priority, we had to start laying the groundwork. We pulled together our interprofessional team, which included performance improvement, infection prevention, our infectious disease physicians, nursing leaders, environmental services, antimicrobial stewardship team, our clinical engineering team, and also information systems. Our executive leaders provided oversight, and we had executive leaders from the physician side, nursing, and operations vice president. We completed a literature review to define our major strategies, and we prioritized a multi-pronged approach for leveraging EPIC decision support and advanced analytics reporting to improve outcomes. Using our RUSH Way standard improvement framework, we went through the steps of truly trying to identify what were our root causes. So first we were ready, right? We established our team, we prepared the team, we defined our process at a high level, determined if there was any just do it's, right, to implement immediate containment if necessary, and obtained executive sponsor approval. Through the understand phase, we established and executed data collection plan. First, you need to collect your data so that you can understand where you're starting at. Established our baseline performance, define our current processes and identify root causes, and then again, seek our executive sponsor approval to move forward. Through the solve phase, we developed solutions, tested those solutions, defined improved processes, and developed and execute the implementation plan. And currently, we're in the hold stage, right? So our benefits have been validated, our process control system standardize and translate, and again, executive sponsor approval. So using the Rush Way Standard Improvement Framework empowers a cross-functional team. It focuses on project management methodology and also strong team leadership. We selected our strategies to control C. difficile here at Rush University Medical Center based on opportunities that we identified during our case reviews. The evidence-based interventions recognized by national authorities included early recognition of C. difficile so that we could implement transmission-based precautions and begin treatment for our patients earlier on, optimize our environmental cleaning, and ensure that we're appropriately testing our patients for C. difficile so that we're not overly testing and overly treating. As it pertains to our reporting and meeting structure, this really is a two-way pyramid, right? So if we start at the bottom here and talk about our nursing task force and ad hoc work groups, we really use our nursing task force and ad hoc work groups to identify barriers. We know what our evidence-based practices are. We know where our opportunities are. Now, how can we break down some of these barriers? We've brainstormed solutions, deployed education. We have our local level champions at this level, and then we also have nursing task force monthly meetings and ad hoc groups as needed. The information from this group is also fed up to the Healthcare Associated Infections Committee. They're the experts on infection control. They meet weekly. They are the approval body for interventions. So these barriers and brainstorm solutions identified by the nursing task force or ad hoc work groups are fed up into this HAI committee, and approval is also given through them to move forward with some of our improvement processes. Our sponsor team meeting is where we have our executive buy-in. They help with accountability and barrier busting. Also, that is a monthly meeting. So all of that information fed up through the nursing task force, which is filtered through the HAI committee, is also brought to the sponsor team meeting, and then ultimately reported up through the Performance Improvement Oversight Committee. This is where the hospital top leadership convenes. They ensure that we have organizational alignment. They help to break down some of those bigger barriers. The C. diff team would report out anywhere between monthly and quarterly, depending on the projects that we were working on, and this is where we get a lot of executive buy-in. For the reporting structure, you can see here that we really were very, very multidisciplinary. It starts at the very top with our executive sponsors to help us align our vision, oversight, and alignment. We had our Vice President of Operations, Associate CMO, and our Associate Vice President of Professional Nursing. Quality improvement really was the key to this project being a success. They really drove that quality improvement process, convened, facilitated, and project managed all of the C. difficile sub-teams and related work. They report directly to the executive sponsors and provided ongoing communication within teams to leaders. So that's our performance improvement consultant. Informations was our leader for IS and our EPIC expert. This was our information systems analyst and chief analytics officers. Infection prevention, of course, is our infection control expert, and that role was filled by an infection preventionist. And you can see here there were many stakeholder groups that were partners for understanding solution identification and implementation. So we had partners from nursing, and when we talk about providers, it's not simply physicians. We engaged physician assistants, clinical nurse specialists, nurse practitioners. We engaged environmental services and clinical engineering, our antibiotic stewardship program, and again, infection prevention. And then we had other stakeholders that kind of came in throughout the project, partners in dietary, partners in linen management, things of that nature. We had champions that were at the work group level decision making, helping us to bust barriers within their area and escalate across areas. So our Associate Vice President of Professional Nursing Practice, our Associate CMO, Vice President of Operations, Chief Analytics Officers, our ID physicians, and many other stakeholders. We had process owners who helped to oversee implementation in operational areas, and they're really our key to long-term sustainability. So that's process owners at the unit level, unit directors, our medical directors, the director of EVS, director of antimicrobial stewardship, infection prevention. And then we also had our frontline expert contributors, so our subject matter experts and process experts help to implement practice and provide feedback on our PDSA. Some of our projects and associated interprofessional teams you can find below. We developed a comprehensive C. difficile bundle, and that was implemented or put together using nursing, our providers, environmental services, and clinical engineering. Equipment cleaning, you can see our best practice alerts used multiple different types of disciplines, medication stewardship, and hand hygiene and PPE use. So when we talk about our intended goals, we had both outcome goals and process goals that we were looking to achieve. Our overall outcome goals were to reduce hospital onset C. difficile SIR to align with the NHSN median. So that means that the SIR we were looking to achieve was 0.93. And so a little refresher, for FY 2016, our baseline SIR was 1.28. So that was a pretty lofty goal. For our process goals, we wanted to ensure early identification of true infections so that we could appropriately isolate and isolate or put patients into transmission-based precautions so that we would reduce the spread of infection. We wanted to make sure that we appropriately tested our patients to avoid unnecessary isolation, so really identify those that had active C. difficile infection. We were looking to improve the quality of environmental cleaning and then improve timely and accurate data communication to clinical and EVS teams to be able to enable them to apply appropriate interventions. We're going to talk a moment about the distinction between colonization with C. difficile versus active infection. As more efficient testing methods have been implemented to test for C. difficile infection, this has also led to an increase in identification of patients who are colonized with C. difficile infection versus those who have an active infection. The PCR testing that many organizations utilize identifies the presence of the organism, but what happens is that we're also identifying colonized patients. Patients who are colonized with C. difficile spores do not have any signs or symptoms, so they don't have any active C. difficile infection. Patients with active C. difficile infection, and these are our patients that require transmission-based precautions and treatment, have large volumes of liquid or loose stool, which then contributes to the transmission of the infectious organisms. The 2017 Infectious Disease Society of America C. difficile guidelines recommend use of the nucleic acid amplification testing, or PCR testing alone, only if patients are properly screened for signs and symptoms of active infection. So basically, if you're going to use this PCR testing, which is what we use, you should be screening these patients to make sure that you're not inadvertently picking up patients who are simply colonized. The importance of accurate testing is kind of twofold, right? So we want early identification to reduce the spread. So we want to seek out those patients who have displayed signs and symptoms of C. difficile infection and identify them and treat them as soon as possible, right? So we're going to improve the patient outcomes by identifying and treating sooner. We're also going to decrease the risk of transmission to other patients by initiating transmission-based precautions sooner. We also want to reduce inappropriate diagnosis. So we don't want to test those patients who may only be colonized with C. difficile infection. So we're going to reduce unnecessary testing. We're going to reduce unnecessary isolation. And again, we don't want to give antibiotics to people who don't need them, so reduce unnecessary antibiotics. Also, the importance of accurate testing helps us to accurately classify community onset versus hospital onset infections. This helps for us to better understand our opportunities to decrease preventable transmission and infection. If we have a lot of patients that come in that should have been tested on day 2 or 3, but they don't get tested until day 7, we might be looking at different opportunities. We want to make sure we have clear outcome metrics for the evaluation of our interventions and accurately benchmark against other organizations. So our problem summary and decision statement. So inconsistent ordering practice was one of our big opportunities. We didn't always have patients that were identified at their onset of symptoms. So again, there's the potential that the patient isn't being treated early on in their course of disease, and also the potential for transmission to other patients. We also have inappropriate orders for patients without clear symptoms or patients that have other known reasons for their symptoms. Nursing and EVS have inconsistent processes for communicating C. difficile cases, which leads to a lack of standardization in their response. We reached out to information systems to determine the options for providing ordering guidance, hard stopping inappropriate orders, to see if we could have an order authorization process, determine if we were able to create push notifications, and also to discuss the use of best practice alerts. Best practice alerts have been shown in this organization to be the best method for helping to hardwire ordering practice. When we talk about nursing, right, so we started with our order guidance PDSA. In May of 2015, our very first nursing BPA was initiated. Basically, the best practice alert would fire based off of the documentation of stools in EPIC. But at this point in time, nurses were unable to order testing. It wasn't until March of 2017 the Nurse C. difficile-driven protocol was approved by the Medical Executive Committee. This allowed nurses to place orders into EPIC for C. difficile testing. There was some confusion about when it was appropriate for nurses to order, and there were many orders being placed by nursing outside of the approved protocol. But this was part of our learning process, right? So we fine-tuned our solutions. We were working on limiting best practice alert overrides. We created an order validation that does not allow protocol orders after day 3, and there was a lot of nursing education that was being sent out weekly to help our nurses along. These nursing best practice alerts were really designed to help encourage earlier identification of symptoms. So prior to admission, we were looking at ED admission assessment form, identifying diarrhea, and instructing them to test the patient on the spot. Once the patient was admitted to an inpatient location, the nursing patient admission assessment identifies diarrhea, so asking the patient if they had diarrhea prior to admission. And then there was also a nursing best practice alert that would remind nurses to test based on their answer to the admission assessment question, any documentation of diarrhea on day 1, or on day 2, 3 or more stools documented. It was the Medical Executive Committee that approved the nursing protocol, allowing nurses EPIC access to order in the first 3 calendar days. If the nurse did not order, if she or he stated they were going to place the order and they did not, an in-basket message would be sent to the associate CMO when the order was not placed per the BPA for follow-up. For our nursing decision support, these are just a couple of screenshots of what we're looking at. So this big admission box here is this admission question, and it asks, was the patient experiencing watery, loose diarrhea stools now or within the past 24 hours? The verbiage has been tweaked intermittently throughout this process, but it is essentially the same. And then the 2 little boxes at the bottom here are just examples of the best practice alert that fires for nursing when they have documentation of liquid loose stools. So nurses document diarrhea prior to admission for all patients. During the first 3 hospital days, the BPA will suggest a C. difficile order. As of April 2017, the nursing protocol allowed nursing orders, and if not ordered within 6 hours, a message would be sent to the associate CMO. So for the best practice alert, promise, progress, and pitfalls, right? So our nursing BPA really did evolve, right? It wasn't like a surefire hit, knock it out of the park on the first try. Initially, our nursing best practice alert fired based on documentation solely of stool and yielded about 100 to 200 alerts per month. We expanded the best practice alerts to fire based on this admission question, so diarrhea prior to admission, which added an additional 500 to 600 alerts per month. There was a progression of verbiage from diarrhea prior to admission to diarrhea within 48 hours of admission, which the net was cast, I think, a bit too wide, and then diarrhea within 24 hours of admission. With the question of diarrhea within 48 hours of admission, we saw an unanticipated dramatic increase of 50% in the number of BPAs that fired as a result of the changes that were made to and as a result, changes were made to optimize the intent of the admission BPA. The BPA was also updated, requiring nurses to make a decision to either order testing or document one of the predetermined acceptable reasons for BPA dismissal. And then the number of admission BPAs returned to expected. So I think one of the examples was we gave the nurses leeway to say the patient has a known reason for diarrhea, when some of those patients with chronic gastrointestinal illness such as Crohn's, ulcerative colitis, multiple manipulations of the bowel actually are at higher risk for C. difficile infection. So those patients were unfortunately being ruled out earlier on. This process set best practice alert standards for our organization, and it changed our internal workflow. So instead of creating the BPA and pushing it straight out to providers to see kind of what happens, the BPA changes are now initially run silently in the background so we can take a look to see exactly what impact this is going to have for our providers, because we don't want provider burnout. When we take a look at our community onset C. difficile infection testing and infection rates, you can see our intervention period was actually 9 months beginning in December of 2017. And then the baseline period was the 23 months prior to that. So our community onset testing rate was 1.08 basically per 1,000 patient days. And with the changes that we put into place with the BPAs and with a lot of nursing education that went out in that December, you can see that our community onset C. difficile infection testing rate went up to 123 events per 10,000 patient days. And you can see also that our community onset C. difficile infection rate rose from 16.8 cases per 10,000 patient days to 20.6. So we were ordering more in the community onset time period, and we were also detecting more in the community onset time period. We then turned our focus truly to our providers, right, ensuring that we had appropriate testing. In March 2017, we put into place best practice alerts to alert our providers of those conditions that we wouldn't want to test patients for C. difficile infection. So patient is on a laxative, the patient has documented formed stools, right, not indicative of an active C. difficile infection, the patient has had less than 3 stools in 24 hours, or the patient has had a previous negative within 7 days. Unfortunately, there were no hard stops, so those BPAs were often ignored. It was in 2017, December 2017, that leadership made the decision to put into place a best practice alert in which the provider needed to consult with infectious diseases prior to ordering a C. difficile test. This practice was put into place to confirm that the patient does not have diarrhea associated with an expected course of therapy, and also to screen for the presence of signs or symptoms of active C. difficile infection, right? So Infectious Disease Society of America did say, right, you don't want to use PCR testing unless you're going to actively screen your patients for signs and symptoms of active C. difficile infection. This is our C. difficile BPA inpatient algorithm workflow. This gives our providers a little algorithm to follow to help them with decision support as to whether or not they should be testing our patients for C. difficile infection. So the first question there is, has the patient had a laxative in the last 2 days? Yes or no, do not test, number of loose bowel movements in 24 hours. And when they get to the bottom here, you see that little green box. If they've answered yes to enough of these questions, they're going to get, and they go to place that order, they're going to get that prompt that they need to page infectious disease for approval. So these are our provider interventions. First, there was the BPAs to warn providers that they shouldn't test, and that's that top box. We changed it to a hard stop BPA that requires an infectious disease provider's name to proceed with the order. Really and truly, it's not a hard stop. The provider still can order a C. difficile test. However, we've seen the culture change. With this initiation of this, the page to the ID docs, we've seen just the sheer number of C. difficile tests drop, right? Makes them stop to think about whether or not they really need to test the patient. And then if a provider does make it through and they don't consult ID, they get a follow-up phone call from infectious disease. So there is a daily report that's sent to infectious disease, to the infectious disease team to ensure that someone approved all C. difficile orders placed the previous day. this is what that little pushed report looks like. So this is part of the provider approval validation process. So you'll see it'll give the patient name and MR number, the alert date where they were at, and the alert comments. So you'll see, a provider name in the right column there. If it's one of our ID docs that was on consult, then it's fine. If not, then they're followed up with the ID doc on the next morning. So some of the reasons for C. difficile non-test approval, this was a review by our ID docs that are actually answering the pages. So some of the reasons why they didn't approve the test was laxative use in the prior 48 hours. The patient did not meet diarrhea criteria, so less than 3 bowel movements per day, less than 1 day of diarrhea, no diarrhea, or clinical syndrome not suggestive of C. difficile infection. And then a couple others, negative C. difficile test in the prior 7 days, or even a patient who had a recent positive C. difficile test. So this is just our hospital onset C. difficile control chart. You'll see the blue line in the middle here, our mean was a bit higher before we implemented that provider BPA, the HeartStop provider BPA in December of 17, and we've seen a significant shift down in our mean. And you can also see that really we have much less variability in our monthly rates. So for our outcome value, when we really evaluated the impact of the mandatory ID specialist testing approval on hospital onset C. difficile infection testing and infection rates, what we've seen since implementation in December of 2017 is a 58% reduction in hospital onset Clostridium difficile infection testing and a 57% reduction in hospital onset C. difficile infection rate. So we dropped from 76.8 tests per 10,000 patient days to 32.6 in that hospital onset time period. And our infection rate dropped from 10.6 cases per 10,000 patient days to 4.6 cases per 10,000 patient days. In addition to the best practice alerts that were designed for nursing and providers, we also created C. difficile pushed reports. So every day a C. difficile pushed report is created and it's pushed out to EVS. EVS utilizes the C. difficile pushed report to identify rooms that should be cleaned twice a day, as well as teams that will receive a SWAT team clean. Nurses utilize the pushed report to confirm that standard work is being done. So they see that their patient is on their unit has a positive C. difficile infection. They're going to make sure that appropriate signage, isolation signage is in place, that the personal protective equipment is stocked, and that there are bleach wipes available on the unit. For our EVS workers, when they use this pushed report, right now the C. difficile report is automatically sent to their EVS leadership. The operations manager reviews the list for twice daily clean and or SWAT deployment. If the patient is positive, they require a twice daily clean, so that first shift will always clean the room, but the second shift turn down team will be notified of all C. difficile positive patients that require a second room clean that evening. If 3 or more patients on one unit are positive for C. difficile, additional staff are deployed to that unit for a deep clean of the common areas. As more patients on the unit have active infection, the same type of active infection, the colonization pressure increases and the likelihood that the common areas will become contaminated increases. Currently, EVS is also investigating the potential use of a locator badge to verify room cleaning. This locator badge would provide real-time location. It's already in use by nursing unit and other unit-based staff, so they're just trying to determine if it could be used for EVS workflow as well. Environmental Services transitioned their paper audits into Epic. So basically, when they are auditing their environmental cleaning, their discharge cleans, they're able to now track this data in Epic to allow for ease in data collection and transparency in reporting. So for this project, we have additional outcome values. It's estimated that we saved $1.2 million in monetary savings over the last 2 years. As we talked in the beginning, the cost to treat a patient for a hospital onset C. difficile case was higher than that to treat a patient with community onset C. difficile case. So as we've started to transition our number of cases identified to community onset as well as decrease our number of hospital onset cases, you can see from FY16 to 17, we estimate that we saved about $421,000, and from FY17 to 18, another $759,000. Other intangible values that aren't necessarily calculated in there is the decrease of use of PPE or personal protective equipment, decreasing our carbon footprint, right? So we're not putting all that, those yellow isolation gowns and gloves into the trash. Increase our patient satisfaction. So if we treat our patients earlier, they get better faster, they feel better faster. And if we accurately identify patients who have active C. difficile infection only, we're not unnecessarily isolating or placing patients into transmission-based precautions. And we're also decreasing the use of antibiotics for a patient who does not need. For a return on investment, so something to remember is as we see an increased number of community onset cases, this increases the burden of C. difficile in the hospital and also increases the risk for transmission. But as you can see here in our bar graph, between 2016, 2017, and 2018, we're seeing our community onset identified cases of C. difficile go up and our hospital onset C. difficile cases go down. So we're not seeing a parallel increase in both. And again, our financial comparison between FY 2016, 2017, and 2018, a substantial decrease in costs associated with C. difficile infection. So this is our final demonstration of our continued commitment to improving outcomes for our patients. As you can see in FY 16, we started off with a SIR of 1.28, which was 149 cases for that year. In financial year 17, our SIR was 1.09 with 123 cases for the year. And in FY18, our SIR dropped to 0.89, which is well below what our goal was with 108 cases. We continue to see improvements. So for the first quarter of FY19 to date, our SIR is at 0.72 with 32 cases identified.
Okay, and we would like to thank our speaker from Rush University for joining us today and sharing their Davies story. This information, this story can be found along with other important Davies use cases, recording, and information on how to apply for Davies. All of that can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Again, thank you for joining us today, and have a good day.